Okay, now our next speaker is Elizabeth Hutchings from TC3 on breast cancer implementation.
Thank you for the opportunity to present my research today. I would like to acknowledge my research supervisors, Professor Fran Boyle and Professor Phyllis Buto, and I would also like to thank the Sydney Vital for their support of my research through a breast cancer research implementation scholarship. Data is pervasive in all aspects of society, and healthcare is no different. In healthcare, the capacity to use data for a purpose other than what it was originally collected, or secondary data analysis, is appealing and has the potential to greatly influence our understanding of disease, but also to inform service planning and health resourcing, all of which can lead to improved patient care. But there remain significant barriers to the reuse of this data, including concerns about privacy, information security, and appropriate methods of consent when accessing this data. For researchers and academics, questions about data ownership and academic acknowledgement are also of concern. My research focuses on the attitudes of patients and healthcare professionals and researchers towards the secondary use of data in cancer, specifically how we reuse health administrative data and clinical trial data. My research was conducted over 3 phases: a systematic literature review, semi-structured interviews, and 2 anonymous online questionnaires, all of which are in various stages of publication. And today I would like to briefly present the key differences between the completed responses from the Healthcare Consumer Questionnaire and the Healthcare Professionals Questionnaire. Results of both questionnaires showed strong support for the ideals of data sharing in cancer, particularly where the data is to be used for reasons of beneficence. Key differences between the completed responses show that compared to researchers, healthcare consumers had higher levels of support for the inclusion of de-identified data in registries or databases, higher rates of support for linking de-identified clinical trial data with other data sets, but similar levels of support for linking de-identified health administrative data, less concern about privacy for de-identified data, but similar concerns about data security. And finally, researchers had higher rates of participation in the COVID Safe app and the My Health record compared to the healthcare consumers. Irrespective of their previous data sharing practices, the majority of researchers indicated that a formal citation of the data providers and all the funding agencies in all disseminated work making use of the shared data was an appropriate method of acknowledgement. While there was clear support for data sharing, responses to our questionnaires were diverse, indicating that the attitudes towards health data reuse in Australia are highly individualised. Given that health researchers are already using data in many research activities, I believe that my research has highlighted the importance of ongoing study in this area. Thank you.